All right, so now we're going to hop into protocol 4I. It's specific causes of cardiac arrest, adult and pediatric. If you remember when you went to EMT paramedic school, they talked about your H's and T's when you're going through your cardiac arrest, trying to figure out why that patient went into cardiac arrest. Obtaining a history of the patient's important, obtaining, what they've eaten, any allergies, any medication changes, narcotics, anything like that. So obtaining that and getting your baseline information out of the way. So your treatment priorities, again, over here in the yellow box, nothing really changes as far as what we've already been over, except for the very bottom point on number 1. If hyperkalemia exists, calcium chloride is your first medication. And then number 2, I'm just going to hit this one more time, even though we've already talked about it, oxygen and ventilation support. I know I've mentioned it and Jake's mentioned it several times, but avoid hyperventilation in your rate and volume, and then use waveform capnography if equipped, and it's mandatory if the patient's intubated. I will say this, it is not mandatory if you were establishing an airway with an iGel, but it doesn't hurt anything. Capnography is the best way to measure a patient's breathing, and so the best way to do it is just get in the habit of putting capnography on any airway that you are taking over and breathing for the patient or whatever. So just put capnography on everyone. That's really the easiest way to do it. So you start up here on the EMR EMT side, or EMR EMT box, sorry. Find possible causes for cardiopulmonary arrest and treat where appropriate. This is the H's and T's we talked about, or we will talk about, that you learned in school. Your hypoxia, oxygenation, ventilation with 100% O2. Hypokalemia, for this level of licensure, is going to be rapid transport. Your pre-existing acidosis, oxygenation, ventilation, 100% O2. Pre-existing hypothermia, prolonged cold exposure. We'll talk a little bit more about this in a later protocol, but just rewarming the patient. Cardiac tamponade, thrombosis, AMI or PE, rapid transport. Trauma, toxins, drug overdose. This is something where you can, as an EMT, give a medication, and it is going to be naloxone, which is also known as Narcan. Here it does say, I want to point this out, so everybody please pay attention. It says 2 milligrams IN may repeat once, and then pediatric it says 0.5 milligrams IN may repeat once. We, on the fire department side and the EMS side, try to not give it IN anymore. That is kind of a former thing that we've kind of gone away from. If it's absolutely required, I'm not going to be a hypocrite. I have done it because that was the only way we could do it at the time. But you should give it either IV or IM, intramuscular, not IN, and IV or IO, either one. So I will say, too, just to add on to that, your dose is 2 milligrams if they are a suspected narcotic opiate overdose. The whole point of naloxone or Narcan, whatever you want to call it, is to get the patient breathing again. If you give the 2 milligrams, there is a chance that they aspirate. So that just causes a bunch of problems for you after they wake up. A lot of people, whenever you take that high away from them, they wake up, they have no idea what's going on. They just see a bunch of strangers, over the top of them, or bunch of people talking or touching them, talking to them, and they freak out and then they want to fight. So just be very careful and mindful of that. This is not something that we just want to slam on people. So you are not wrong for giving increment doses of naloxone, regardless of how you're giving it, whether that be IM, IV, IO. Just remember when you're giving it different routes, it will have a different time frame on when it will kick in, when it'll start to work. Obviously, your IO, IV is going to work the fastest. So if you're going IV, IO, you may start with the 0.5 or you may start with 1 and give increments of whatever it is. Get the patient breathing and then treat your patient. You don't necessarily want to just wake them up automatically. So with that being said, your pediatric dose, 0.5 milligrams, IVIO, IM, and then IN if you absolutely have to. So we'll scroll down a little bit farther. This is for your intermediates and advanced. Find possible causes of cardiopulmonary arrest and treat where appropriate. Hypovolemia, so trauma patients or whatever it is, 1 liter normal saline, IV, IO bolus, if there's no signs of pulmonary edema. For pediatrics, it's going to be, and this is something you might want to remember, 20 milliliters per kilogram, normal saline, IVIO bolus, if no signs of pulmonary edema. For hypoglycemia, if the blood glucose is less than 50, your adult or pediatric, it's D10, 5 milliliters per kilogram, IV push bolus, wide open up to 250 milliliters, or D25, 2 milliliters per kilogram, IV IO up to 100 milliliters. You must be at least 1 year of age. Or D50, 1 milliliter per kilogram, IV IO push up to 50 milliliters, and you must be 25 kilograms. In cardiac arrest, we will give D50. We will not give D50 on anything that is not cardiac arrest anymore. That's when we go with the D10. But if they are in cardiac arrest, we will go with the D50 to try to get their blood sugar up, or blood glucose. So for advanced EMT or higher licensure, nothing really changes as far as what's said above. And then your paramedic licensure on the very bottom. So for hyperkalemia, you're going to give calcium chloride, 10 milligrams per kilogram, IV IO push, max of 1 gram, and sodium bicarbonate, 1 milliequivalent per kilogram, IV IO push, max of 50 milliequivalents. So you're going to give both of them for hyperkalemia. You will not give one without the other in this instance. So if it's known hyperkalemia, you will give calcium chloride and sodium bicarb. For toxins and drug overdoses, suspected tricyclic antidepressants, you will only give sodium bicarb, 1 milliequivalent per kilogram, IV IO push, max of 50 milliequivalents. So this is where it kind of gets tricky, because you'll hear people say, well, you can't give one without the other. It's only in specific causes that you can't give one without the other. And then there's specific ones where you only give one of them. So this is one of them, your tricyclic antidepressants. If you're not familiar with tricyclic antidepressants, I encourage you to Google a couple of them, and you'll be very surprised at the amount of people that you've ran on that they say they're on this medication, and it is a tricyclic antidepressant. So that's your sodium bicarb, 1 milliequivalent per kilogram. For suspected beta blockers or suspected beta blocker overdoses, that is going to be glucagon, and it is 1 milligram IV IO push, or for pediatrics, it's going to be 0.5 milligrams IV IO push. So then down here, just below that, it's going to talk about suspected calcium channel blockers. That's going to be only calcium chloride. So that's calcium chloride, 10 milligrams per kilogram, IV IO push, max of 1 gram. And then your tension pneumothorax, that's going to be your needle decompression that we'll do later on in skills, and we'll talk a little bit more about that in trauma. But we also, I say that, with that being said, we will do needle or chest decompressions in cardiac arrest patients in certain cases, and we'll hit that a little bit farther. I won't dive too deep into that. So just a little refresher, paramedics, if it's hyperkalemia, you're going to give calcium chloride and sodium bicarbonate. For a tricyclic antidepressant, you're just going to give sodium bicarbonate. For suspected beta blockers, you're going to do glucagon. And then for suspected calcium channel blockers, you will just give calcium chloride. And that's going to be it for that one. We will hit a little bit more in detail once we hit the formulary section, when we give those certain medications, what we do and stuff like that. So we'll get there here in a little bit. But that is it for that one.